Harish, are you there?
Hello, everyone. Hello,
Hey.
John. Hello, Professor Patel. Shikha. Hello.
Yeah, I can hear you.
Can you hear me?
Yeah, I can see you though.
Okay.
There you are. Nice background.
Mm.
How are you doing today? Harish?
Hello, Dr. Bennett. How are you?
Hey, listen, Harish, I don't know if she's going to show, so otherwise you want to introduce the king?
Sure, I would love to.
Okay, now you're from Mumbai?
I'm from Gujarat.
Oh, Bhopal,
Not from
right? Bhopal?
Yeah, Bhopal.
Bhopal. Do you know Atta Bhatti? He's a neurosurgeon from Pakistan originally. He's now in Switzerland. And
Okay.
this is Harish, an up-and-coming neurosurgeon.
Hello, nice to meet you, Dr.
Thank you.
Bhatti.
Sure. Thank you.
We're
What made you choose neurosurgery?
Yeah, we're trying to get the dual neurosurgery going. And hopefully Atta can come tomorrow night to
You are tackling so many different questions
a
from different
doctor
angles
from
perspectives and at different scales. The environment really pushes me to think bigger, and I enjoy the collaborative and
hello,
creative aspect.
Uday. Do you want to be?
I
I guess you don't want to be. So you might make it tomorrow night, huh, Atta? You can be the host tomorrow night if you want to, Atta. Okay?
Yes, you can.
It looks like a good one. AI and stroke.
Mm.
You're happy you're in here, right? Oh, there you are.
Hi, John.
Hey, good morning. How you doing?
Good, I'm good. How are you?
Good, good.
Yeah.
So the king will be here in a few minutes, right?
Yeah.
Okay. 2 hours today, right?
Yeah.
No, that's okay. I'm sure people won't mind.
Yeah.
Good morning, Uday. Good morning, Uday.
प्रोग्राम का जो सेशन है वो he's doing है from Miami से he's doing so he hosts all these programs in Miami से basically इनके पास servers हैं सारे so it's just like हम प्लेटफॉर्म हमें मिल रहा है बट सर्वर्स जो है वो वहां पर है
Sure.
Patel, you're a med student, right?
Yes, sir.
Last year, your last year, fifth year?
Yeah,
Okay.
in my final year.
Okay. Here's the king. Here's the king. Okay, up horns, up violin. Up violin. Oh, why am I? Good morning, the king is here. How you doing, Atul?
Good
Welcome.
morning, John. Good morning, and good evening, and good night.
Okay. Okay, we're all waiting here. A 2-hour session today, right?
Yes, yes.
Yeah, that's great. That's great. See, so far, Harish Patel, he's a med student from Bhopal. He's going to be introducing you.
Good evening,
Okay.
Dr. Goel.
Good evening, good evening.
I'm Rishikesh, a medical student from AIMS Bhopal.
Very
Uh,
good, very
He's a
good.
big fan of yours, Atul.
Okay. He's the number 2 after you.
Yeah, that's it. Okay, Uday's here. Uday, say hello, Uday.
So, good evening to all. Good evening, Dr. Atul sir.
You must be in a bad place.
Good evening, Uday. Good evening. Where are you?
I am in Delhi at present. I am doing a fellowship in neurointervention.
Very good, very good.
Okay, do you want to start?
Okay,
Atul?
you want to start?
Wait, I got something else going on.
Good evening, sir.
Hello,
This is Dr. Arjun.
Hello.
Good evening, Arjun. Good evening, Arjun. There's a lot of echo.
If someone has a microphone on. Someone has a YouTube. Could everyone please check their YouTube? Someone has a YouTube on. It's Harshad. You hear that echo? Somebody has a YouTube on. Please check your settings. And get off the YouTube if you can. Hello? Okay, someone's got it.
Hi, John.
Hello, welcome, Harshad.
Thank you. Looking forward for the new book of neurosurgery from King.
There we go. Live.
Yes, waiting.
You're seeing a live book.
Large book, yes. The infinite big book.
Big book.
Yes. The King has a king size book.
That's it. There we go. Get ready. Are you ready?
Ready.
Okay, here we go. 10, 9, 8, 7, 6, 5. Oh, no, wait. I gotta put. Let me make sure I'm on here. Oh, okay. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach, Dr. John Bennett, broadcasting another webcast of the King, a special of the 2 hours with the King. And we have some distinguished panelists. The first one I'll introduce is Harish Patel. He's a med student, 5th year from Bhopal, India, and he'll be formally introducing Dr. Goel. Okay, Harish, it's all yours.
So, hello everyone. Sorry for the interruption. Hello everyone. I am Rishikesh Patel, medical student and moderator at the Neurosurgical TV. Today we are honored to have the king with us, Dr. Atul Goel, and he will be talking about his book of neurosurgery. So thank you so much, sir, for sparing the time, and we are very interested and excited to hear your talk. Thank you so much.
Okay, John, ready?
Yep, all set.
Can you see the slide, John?
Yes.
Okay, my dear friends, before I start, I wish to invite all of you to join me in the 5th Asian Congress of Neurological Surgery that will be next year in July, August in Mumbai. I hope and I wish that you can join me. So today for 2 hours, so that is a little bit short time, John, but I will try to present my work in cranial neurosurgery. My spine neurosurgery I will present on another occasion. So my cranial book of neurosurgery. So basically it is like a solid, you have to be solid to give such a title. And I hope and I wish that I remain solid like this for several more years to be able to talk confidently and positively and give you some new versions, some new thoughts about my life in neurosurgery. So if you have to do some solid neurosurgery, you have to have a fantastic and a very supporting family, and this is my family. My daughter is in neurosurgery. She is in the 6th year of neurosurgery. My wife is a neuropathologist, and here I am. And this is these are 2 brothers, my mother and father. He was my first teacher in neurosurgery, Dr. U.S. Vengsarkar, one of the very well-known neurosurgeons from India. His work on trigeminal neuralgia in particular is very well-known. And I couldn't dare to put my hand on his shoulder and laugh with him like this all his life. But in his later part of when he was not so well, I could manage to put my hand and laugh with him, Dr. Vengsarkar. These are my other teachers in neurosurgery, Dr. Sunil Pandya, Dr. Karapurkar, Dr. Nagpal, Dr. Dastur, and Dr. Kothari. So these are the people who have not only stimulated me, but have taught me what to be what I am today. So here Dr. Sami, Dr. Vinod Lahiri has been my partner for several years of my life, and Dr. Kothari has been my partner for several years of my life. And just to introduce this man, he, in my view, is one of the greatest philosophers of medicine ever lived on this planet. And I will show you some of his work with me. What makes me proud and what makes me solid is my publication. And here you see my number of my publication on PubMed, in internet on PubMed, Medline. The number is 810. Of course, this includes several letters to editor, several editorials, but whatever said and done, these are the publications, and the number of techniques that I have published in various presentations of mine is 290, and this number is not 291 or 289. So this number, I keep a close watch on this number. And in 1994, you see this 1994, this is the letter to me from British Journal of Neurosurgery from the editor. He has written that your technique will be published after 1 year because all the slots of technical notes have been taken by you. So this was one very interesting letter from the editor, and it made me proud and it made me very happy. So these are my various editorial positions that I hold and I have held. So I was most prestigious, of course, as chairman of Journal of Neurosurgery Spine in 2014 and 15, World Neurosurgery, and editorial board member of several journals that you can see here. And this was one very favorite picture of mine with JNS Spine editorial board, and I'm standing behind John Jane, as you know, and other editorial board members. So 2 of my 4 books that we have written, these 2 books, one is on cranial neurosurgery essentially, and one is on spinal neurosurgery. So the spinal neurosurgery, I will talk probably on Wednesday. Today, the main presentation topic will be cranial neurosurgery that I have done. And basically also you have to know this is a personalized kind of presentation. Here I'm going to show you the work that I have done and the contributions that I have probably made to this subject of neurosurgery. So this is the book where, if you see, the cover page is quite a strong cover page, and here you see a lot of petrosectomy has been done, gastrian ganglion elevated, superiorly carotid artery elevated anteriorly. This is total petrosectomy. Facial nerve have been mobilized posteriorly after cutting GSPN, and this is the petrosectomy that was done several years ago. Total petrosectomy, of course, I don't do, but at that point of time during my career, in all my cases, no matter what, the drill had to be used, and drill had to be used elaborately. But I have probably, because of the numbers, or probably because of the experience, my exposures have now become quite limited. The timing of my surgery has become much faster, and the extent of resection may not be as complete as it was before. But I'm sure there is no question that the results, which is the most important issue in neurosurgery, have certainly improved. As I always say, in neurosurgery, there are 3 or 4 things which are very important. One is your technique, how your technique is. Second thing is how much you are using your technology to facilitate your techniques. The most important thing that is in neurosurgery is your philosophy and your concepts. And one thing I have also realized, that the more than concepts, more than techniques, more than philosophy is your experience, how much you have done, for how long you have done, and how many cases you have done, how many times you have ventured into complex region. So experience is the most important. And fortunately for me, I became a neurosurgeon when I was 27 years old. I became chairman of my department when I was 37 years old. So I have got, my department with KEM Hospital, which is one of the biggest public hospitals in the country. And that gave me opportunity to go on operating all the time. And that gave me the numbers, that gave me the complexities, and that gave me the face to be able to face you in this lecture. And the confidence with which I am talking is by virtue of the hospital where I have been for several decades. So this was amongst my first little contribution in neurosurgery, where when as a resident and a junior neurosurgeon, I was asked to do posterior fossa tumors like medulloblastomas and epidermoids. And I realized that wherever shunt had to be done before operation, because that was a common norm in these cases, and still it is a norm. And this paper, according to me, is an underrated paper, very fantastic paper, no question about it. You should not do preoperative shunts, because hydrocephalus is a protective maneuver, and it protects the brainstem from the compression of the tumor. Similarly, we said that tumor-induced hydrocephalus and edema are natural defense mechanism. Tumor-induced hydrocephalus and edema. Similarly, we said during the same 1991 or 1992, this editorial of mine, that syringomyelia is not a pathology, but it is a natural protective phenomenon. So these were my early contributions in this subject, which I believe are, a little bit underrated, but very powerful statements. Before that, all syringomyelia shunt was done, and for all hydrocephalus, of course, this is still done, but my answer to that question is it is negative or harmful. So these are some of my articles on this subject. In thalamic tumor, it should not be done. In supracellular tumors, it not. And these are all published in during that time. Of course, even now, British Journal of Neurosurgery was a very high-profile journal. So these are the publications in that journal. So another thing I want to remind you, and I want to let you know that every sentence which I'm going to talk to you is published and published in high-profile journals. So you remember that. And that makes me proud, and that makes me, positive. Cavernous sinus has been my life. All my life, I have been working within the confines of those small dural corridors of cavernous sinus. And all those who are interested in this subject have heard me several times in my life of cavernous sinus, since this was my article that was published in 1996 on speculations about the function of cavernous sinus and what is the role of cavernous sinus in eyeball movements, in eye protection. Like for instance, if you press your eye like this, if it was not for cavernous sinus, your retinal artery would have burst, because retinal artery is not having any muscular layer. And there is such a big hydrodynamic system of eyeball, the lens, the various fat compartments, and the cavernous sinus, which protect the eyeball, make it move and make it, the vision is there, and so many things. I cannot go in much detail, but these are speculations which you will like to read. And some of these speculations are real, fantastic in my view. Like, for instance, why the eyeball of the lion is located in front, why the eyeball of the deer is located laterally. So these are some issues. So this statement I made, which is quite a solid statement, if you can realize that cavernous sinus has a role. It is not just nerves like third nerve, sixth nerve, but even cavernous sinus has a role in movements and in vision. It is such a quite a powerful statement. So cavernous sinus surgery has been my forte and my life for several decades. And to approach cavernous sinus, to approach pituitary tumors, to approach clival tumors, we have learned skull-base surgery has evolved over the years, and I have evolved myself in the subject over the years in skull-base. So if you see this slide, this in 1996, exactly 30 years ago, we did an extension of subbasal temporal exposure by doing mastectomy in the exposure. So subtemporal exposure with mastectomy was the first time in the literature this was described. So we, instead of the convention at that time, orbitozygomatic osteotomy and zygomatic osteotomy had become quite popular. So instead of those things, we did resection of root of zygoma, roof of condyle, roof of external ear canal, and mastectomy to have a basal exposure for petrous apex lesions. So this article was published in 1996, 30 years ago. So, and this was the first time in the literature. We also modified this exposure in various ways, like incision, taking the incision of this kind, rotation of temporalis muscle anteriorly. Then we started splitting of the temporalis muscle to have, as we progressed, limited our exposure and splitting. So this is also a very useful technique that we described several years ago. And with this kind of basal exposure, I published several articles during that time on pictoclival meningiomas, on trigeminal neuromas. Cavernous sinus surgery was not very profound in 1991 and 1992. It was not very popular, and not many people used to do. It was just an evolving subject. And there are several articles of mine during those years. And some of these articles are, in my view, are quite a game changer. Like what is the impact of arterial displacement, how to do surgery, what to do, and the most important is meningeal architecture of cavernous sinus. Not many people understood this in about 30 years ago. This was article on extradural approach to lesions on the cavernous sinus. You can see this title. For tumors, you see Dr. Vinko Dollans had described for vascular lesions, aneurysms and all extradural approach. For tumors, this was the first article in PubMed or in internet describing tumors. And even Vinko Dollans had acknowledged that this was the first paper on tumors. So how to understand the dural architecture, how to make the peel of onion like architecture and go into cavernous sinus. Cavernous sinus is an extradural entity. So this dura is such a mother dura matter. And this sentence of mine, those who have heard me for several years, this is a very favorite sentence of mine where I say that dura is like mother and mother protects and mother cannot be transgressed, not in by anybody, but more importantly by tumors. And this understanding has a potential role for complete different version of tumor surgery, which believe me was not there earlier. Cavernous hemangioma is one tumor which is placed right inside the cavernous sinus confines. We described that the dura of the cavernous sinus can never be transgressed in these benign tumors. And I described this extradural approach to cavernous sinus hemangioma for the first time in the literature. And there is no question, those who do cavernous sinus hemangioma will have to follow this route. Otherwise, they are unnecessarily doing what they are doing. Some people may like to do by endoscope or nasal route, which I completely disagree. This is another paper where we had said we had identified an aneurysm with intracavernous hemangioma. So this tumor, you see, has specific mode of extension into the sella, into the orbital area, but remains confined. And this article in 1991 was for the first time in the literature where a preoperative and postoperative image of cavernous hemangioma was shown by images. So this was one achievement of mine. No matter how big the tumor becomes, the mother dura remains intact. So this was my concept. And this article we published a few years ago with an experience of 45 cases, which is the largest published experience on this subject. Trigeminal neurinoma is another subject of mine. This article, which was published in 2003 with an experience of 73 cases, is amongst the topmost cited article in the literature on trigeminal neurinoma. In this article this is the largest experience at that time. Second thing is we said that this part of tumor is interdural for the first time in the literature. We said that trigeminal neurinoma arises in the Meckel's cave in the region of gastrin ganglion. For the first time, we said that this tumor, when they go extracranial, it remains within the dural confine. So these were several things. And another very beautiful thing we said in this article was that you can not only preserve the trigeminal function, but you can improve the trigeminal function. So this statement as a series was presented for the first time in the literature. So this was quite a heavy paper, and this is quite beautifully cited. So interdural, this term interdural approach was described by us like this was the first time in the literature where we removed a tumor and joint in the region of cavernous sinus without craniotomy. So if you can see this picture, zygomatic osteotomy is done. Meckel's cave is opened by opening the foramen ovale and the tumor is removed. You see this title, infratemporal interdural approach. This is the first time in the literature such a tumor which were quite complex. Not only in 1995, but even now they are complex. But this tumor was removed by understanding that, yes, this is trigeminal neurinoma, and yes, you can do it by not exposing too much. It will remain within the dural confines, and you can work within the dura to remove this tumor. So my experience was 73 cases in 2003. And now my experience is nearing 400 cases, which is beyond doubt the largest experience in this subject. So this was trigeminal neurinoma. First thing is you have to identify that this is indeed a trigeminal neurinoma. Second thing is on the basis of clinical findings. Then you have to know that the anatomy of this tumor. Open the dura, just open the metal scale and remove. This another tumor that you see here was going in the posterior fossa, and this is my craniotomy. So understanding that this tumor, posterior fossa tumor, can also be removed without craniotomy. So this was, you see, there is no craniotomy here. So first time I will say a petroclival tumor was removed without a craniotomy in the history of neurosurgery, and this is a fantastic thing. When the tumor goes extracranial, we said that these tumors are within the confines of dura. Nobody has said this. Even when it is in the V1 division, V2 division, V3 division, this extracranial part is within the dura. This has great implications because you can work within the dura and you can avoid the nerves and arteries in the vicinity, in the region of the eyeball, work within the dura. And we said that you can remove this tumor by a reverse transcranial interdural. This paper was published in Journal of Neurosurgery and quite a heavily cited article. Even when the tumor recurs, trigeminal neurinoma recurs, it is within the dural confines. Similarly, we talked for the first time in the literature about third nerve neurinoma, that it arises from the region of oculomotor system. That is one thing we said. Second thing is when it becomes large, it is covered by dura. This is another beautiful thing we said. Third thing we said that if you understand this relationship of dura with the third nerve, you can preserve the third nerve, which nobody has said in the literature on third nerve neurinoma. So this is, you see, this is post-operative. Patient has preserved or improved third nerve function. Then we talked about seventh nerve neurinoma. You see, these are complex skull-based tumors. One can expose these tumors for 10 hours or 15 hours. We said that this part of the tumor and this part of the tumor is within the dural confines. These tumors arise from the geniculate ganglion. Nobody had said this before. Geniculate ganglion. As it becomes big, it remains within the dura. So if you have this understanding, you can come lateral, open the dura, attack the tumor. And you have to be protective of the dura, and you can probably save or preserve the seventh nerve function, which is very difficult or impossible, but it is a possibility. So this interdural location of seventh nerve neurinoma was described for the first time in the literature. Similarly, we talked of lower cranial nerve neurinoma, that they are interdural. Imagine such a big concept. And in this article, if you read it between the lines, you will find out that for the first time in the literature, we said that there is a possibility of improvement of function of lower cranial nerves. So nobody has said this. So if you realize that these tumors are within the dura, you make an incision in the dura, have a wide exposure, work within the dura, and you can probably save the lower cranial nerve function. So when the tumor is intracranial in the temporal bone outside, have a big exposure of the mastoid bone, have a big exposure in the junction of the head and neck, and then take an incision in the lateral wall. You don't have to remove the lateral wall. If you remove the lateral wall, you will certainly have great difficulties. Another subject which is very popular in skull-based surgery is surgery of chordomas. If you ask me in my life of neurosurgery, which is my favorite article, I will say this one. This was written in 1995, where we said that the chordomas arise in the region of the bone. It is a bony tumor. It displaces the soft tissue. It displaces the carotid anteriorly. It displaces the cavernous sinus and the nerves superiorly. It is an extradural tumor. You will not believe how important these relationships are. Those who are in this business will realize that this understanding can be a game changer in the treatment of chordomy. So that is why I like this article. And according to this architecture of the tumor, this relationship of the tumor with carotid and with dura, we described in 1995 this middle fossa subgastrian ganglion approach to clival chordoma. In my view, this is one very philosophical, still very relevant, and very popular approach for chordoma, although people are now started using endoscope for all these things. But my feeling is this approach is also relevant, particularly in selected cases. So this is the article which I was mentioning. In this chondrosarcoma, you see the carotid should be in the petrous bone here, but the whole structure is displaced laterally, carotid, and the whole cavernous sinus is displaced superiorly. Also, we said now, recently we said that the sixth nerve, goes away from the carotid artery towards the family of nerves. So sixth nerve divorces the carotid, comes closer to the family, and it is displaced on the dome of the tumor. Believe me or not, it's very, very critical and important relationship of chordomas with carotid and sixth nerve, because many of these patients will come with sixth nerve affection. So this is the middle fossa subgastrian ganglion approach to claval chordomas. In my view, very beautiful approach. More recently, we have described supracerebellar approach, of course, in very selected cases, like this one. This patient, you can come lateral. Of course, it is possible. You can come from the nose. I don't think it's a good option. You can come from lateral supracerebellar. Identify the sixth nerve early in the operation, preserve the nerve, and work in this direction, and you can do a beautiful resection. Many of these tumors are very jelly-like soft tumors when you can do a quick fire resection. So this is another case where I have done this. Petroclaval meningioma is, as we all know, is a life of all skull-based surgeons. I must say petroclaval meningiomas are the ultimate, most dangerous, difficult chapters of neurosurgery, but it is indeed a part of neurosurgery, part of our commitment to neurosurgery. Difficult but possible. That is the slogan that I like to make. And this opportunity that this situation of mine gave me, that I have been operating on petroclaval meningioma for at least 35 years now. And I can, to an extent, imagine what kind of tumor it will be. I can smell the consistency of the tumor, the color of the tumor, the vascularity of the tumor, the relationship of the tumor on the basis of imaging. So experience is such a critical and such an important issue in all neurosurgery in general, and petroclaval meningioma in particular. So this was in 1993. You can see the very mega exposure. This was in 1997. This patient taught me several new brand lessons and important milestone in my life. Then we did another beautiful expansion of the petroclaval, expansion of the Kawase triangle. This is the facial nerve. This is the labyrinthine segment. This is the geniculate ganglion, tympanic segment, and mastoid segment. So what we did was, as my drill was always functional, as my diamond burr, this burr, that burr, all the time in the theater, I cut the GSPM, displaced the carotid artery, mobilized the facial nerve, and had a big shot at the petroclaval tumors. I used to do, and this paper is also quite referred by, even Hakuba referred this article, Ohata referred to this article, and various other people, and this approach. Not very frequently used, but it is, of course, an approach. More recently, I described a very popular approach and very fascinating approach to petroclaval meningiomas. That is lateral supracerebellar, posterior cranial fossa, supracerebellar approach. And this approach is, many people are very happy and this is one of the favorite approaches that have now taken over many other approaches. More people like to do in sitting position, and some of my good friends are using. Of course, Dr. Sami had described CP angle approach like acoustic tumor, but this supracerebellar word was used for the first time in the literature in this article. And I did 28 cases at that time. Now a large number of my cases, I'm using this approach. So this is the tumor, and there is some tumor residue, but you can imagine how much to remove, when to remove, how much to leave behind, what is the relationship of small perforator, if you damage one little perforator, what can be the consequence? If you damage the sixth nerve, what can be the consequence? You have to understand these tumors. It is not just a go and remove. It is not a showmanship. It is dealing with very important human life, and that is many things are important. When this tumor is in the Meckel's cave, if it is in the cavernous sinus, then you cannot remove from posterior fossa. Then you have to use middle fossa approach, because in sitting position, you just cannot operate on cavernous sinus, because this venous bleeding, there can be a danger of air embolism. This is foramen magnum tumor. At that time, lot of extreme lateral, far lateral approaches had become very popular during 1990s and all. Dr. Shekhar, my teacher, had and Dr. Sen had popularized that technique. Then came far lateral transcondylar approach. So in 2001, I described this approach, midline approach. No touching of the condyle. Getting into the tumor, identifying the cranial nerves and attacking the tumor. In neurosurgery, in tumor surgery, the most important issue is how to attack the tumor, how to debulk the tumor, how to demolish the tumor, and then remove the tumor, and then dissect the tumor from adjoining cranial nerves and adjoining blood vessels is the most critical part in tumor surgery. That has to be understood more than exposure. So this approach, conventional posterior suboccipital midline approach, has become, many people like this approach and many people use this approach. So this I described in 2001, and I thought that this is also quite a popular version. Meningiomas, the other, you believe me or not, one beautiful sentence I would like to give you. No tumor is curable. Never say I have removed the tumor totally. Never say that I have cured the tumor, cured the person. For meningioma, you say I removed Simpson grade 0, Grimson grade 1, and I have cured the person. Never say this, because you can never cure once a tumor, always a tumor. Once acoustic, always a tumor. Once a meningioma, always a meningioma. So you remove the tumor within the limits of safety. When you have to dissect a perforator for a period of time, like if you are dissecting a perforator for 20 minutes, I will say that is completely a wrong kind of a technique. If you have dissect a cranial nerve, like if you are near the cranial nerve and going on dissecting for 10 or 15 minutes, it is a wrong kind of a understanding. You leave that tumor behind, because you can never cure. You just remain safe, and that is even for acoustic. You have to remain safe. This beautiful favorite article of mine, which I would like that you read this article, Surgery for Malignant Tumor, Beyond the Lure of Technically Sweet. So this, this sentence, if you like to read, from Oppenheimer, who was one of the greatest scientists of all times, who made the atomic bomb. And when he put the atomic bomb on in Japan, after that he became almost like a abnormal and eccentric person. I should not say, but he became very aloof and an isolated person all his life. He said whether that invention was good enough. Similarly, you do all kinds of exposure and all kinds of radicality and total bone removal and complete vertebrectomy for malignant tumors and chordomas, for that matter, and then you say I have cured it, means that is technically a mastery, technically like an atom bomb. But whether you should have thrown that atom bomb is an issue. So this is one beautiful article that you will like to read. Another fantastic work that I think we have done is surgery on pituitary tumor. I have no hesitation to say, believe me, I have no hesitation to say that we have completely revolutionized pituitary tumor surgery. So I will like to show you, these are some of my articles which you will like to read, and I want to show you what revolution we have done. So for the first time in the literature, you see this large tumor. For the first time in the literature, we said that the tumor is cellular and supracellular, but the supracellular component is under the dural roof of diaphragm celli. This is dura of the diaphragm celli. So it is intracranial, all right, but it is infradiaphragmatic. So this statement nobody had made before, and this part of the tumor was considered to be subarachnoid in location. That is why the whole world was doing 25 years ago transcranial surgery for such tumors. Even these nubbins are under the dura. So this tumor, when they do not go in the cavernous sinus, I call them grade 1. This tumor, when it goes in the cavernous sinus, I call them grade 2. But here the lateral dural wall is preserved, the diaphragm celli is preserved, the whole tumor is within the confines of mother dura. So this is grade 2. Now grade 3 also we describe for the first time in the literature. This kind of nubbin, which is very common for large pituitary tumor, is an elevation of dural roof of cavernous sinus. This is dura of the diaphragm. This is dural roof of the cavernous sinus. So if you understand this is within the dura, your surgery can be different. And these things, in my view, are complete, or there is no question, complete revolution in pituitary tumor surgery. Encasement of carotid artery and the arteries of circle of Willis. This is grade 4, and such tumors are indeed quite rare. And when they are there, I call them, they have not respected the mother dura, and they are like those who don't respect mothers, they are malignant children, and those tumors which do not respect mother dura are malignant or aggressive pituitary tumors. So there are several articles of mine in diaphragm celli and what are the contributions. Our contributions on the subject have been mentioned and discussed in several articles on this subject. So I have been operating on giant pituitary tumors for several decades of my life. This tumor, you see this kind of tumor 25 years or 30 years ago, the whole world would have done it transcranial. Nobody, even today, at least 90% of people would like to do transcranial. But in 1998, can you believe, I just made this incision, learned the art of breaking the tumor, break the tumor, deliver the tumor, and get the diaphragm, dura into picture, and you can give a beautiful new life to these patients. This is another tumor I did in 2001. Can you believe this tumor, such a huge tumor, on the basis of understanding that the dura will be intact, on the basis of understanding that you can deliver this tumor. I removed this tumor in 2001 by not even tuberculum sedi and planum spread, no drilling of this or removal of this, just here, get the tumor, get the tumor, get the tumor, and bring it into your surgical field. So various tumor and this elevation of dural roof of the cavernous sinus. You see, nobody had described this dural roof of cavernous sinus, and this you can, if you know it, you can do it. If you don't know it, use talk of any kind of interclinoid ligament and all those kind of unnecessary things, but you cannot remove it. So this was another article on fluid levels in cavernous in various tumors, in intramedullary tumors, in schwannomas, in pituitary tumor. And when this fluid level is there, the tumors are more aggressive and the recurrence rate are much higher. And in the recurrence also, you will find this fluid level. So these are special tumors, and these special tumors have to be really understood. Nasopharyngeal angiofibromas are another difficult chapters in neurosurgery or ENT surgery. Small tumors are different, but large tumors that involve the cavernous sinus are different and dangerous and difficult because they are highly vascular. So we said that these tumors are not only extra cavernous, but they are extra cranial, and you can develop a plane of dissection. I described this transcranial approach in 1994, 31 years ago, for these tumors. You can see this extended transcranial approach that we described, but now I am saying such transcranial approach is not necessary. Another very common tumor in which my experience is larger than anybody else in the literature, epidermoid tumors. Epidermoid tumors, we have said that these tumors arise in the region of tentorial hiatus, or they can arise wherever there is space, they arise. But majority of the tumors are in the region of tentorial hiatus. And this tentorial, these tumors, you just see this tumor. This tumor was labeled as CP angle tumor. This is, of course, CP angle, but this is in relationship, most prominent relationship is the tentorium. So it goes down in the posterior fossa, it goes up in the middle fossa. So this tumor, we labeled it in 2006. This article was published, and I think quite a beautiful article where we said that the supracerebellar approach to epidermoid tumor is the most relevant. Not CP angle, supracerebellar. Come supracerebellar, start removing the tumor, and we have got a huge experience in these cases where we have said supracerebellar, not CP angle. So this approach was described for the first time in the literature by us. And these are pineal region epidermoid tumor, also one of the largest series that we published, supracerebellar approach, and some beauties, philosophical beauties of epidermoid tumors. You will like to read this article. My philosopher, teacher, and my absolute greatest philosopher of all time has written this article with me on epidermoid tumors. I wish that you read this article. Endodermal cyst, we have the largest experience in the world. We said in this article that these tumors are like colloid cyst, and these tumors have a very thin wall. These tumors, the thin wall is in close proximity to critical nerves and vessels. So in case it is difficult, you can leave the thin wall. This is what we have mentioned in this article, and the results, follow-up and all those things. These are, they look very dangerous and difficult, but they have characteristic radiological. You see on T1 white, on T2 black, this is characteristic endodermal tumor, endodermal cyst. These are benign tumors. They are more often in the region of foramen magnum and anterior to the brainstem, and then you remove it. If you have to leave some shell, you can leave some shell behind. So over the years, we have done several difficult, dangerous, impossible cases. One of the cases I did very recently, you see this is glomus tumor, and this is heavily vascular tumor, and we removed it in very quick time. And the patient also, unfortunately, I don't have the picture of the patient, but no facial, lower cranial nerves improved, gait improved, and all those things. My life in meningioma has been quite intense. All neurosurgeons boast of their experience of meningiomas, and I am boasting in front of you now. This paper was published in 2002 with 70 cases. This was the largest personal experience. This article was published on olfactory groove meningioma, and this was the largest personal published experience on olfactory groove meningiomas. This anterior-clinoid meningiomas are another difficult chapter of neurosurgery, where it is important to have a beautiful technique. It is important to have the support of technology. It is important more than anything else to have a philosophy. One single damage to the perforators of the anterior cerebral artery or middle cerebral artery or anterior communicating artery in this region can be absolute. So you have to be safe and you have to be sure. So cavernous sinus meningioma, this beautiful articles compilation, this article, cavernous sinus meningioma, some philosophical issues are there. You must read this article and some other articles on meningioma. So this article, I wish that small little letter, which if you see this, I had written for some article, and what I had written is some beautiful. So in meningiomas in general, if I have to make some statement and which is different from what is in the literature, my understanding is clear and my understanding is definite, and my understanding is that curing, you don't talk of curing of a meningioma. You talk of symptomatic relief. You talk of safety of surgery. You talk of healing the patient. You talk of, improvement. You don't talk of cure. And Be safe, and sure. And recurrence of a meningioma is completely and entirely independent of the extent of tumor resection. This is another thing that is not commonly referred to in the neurosurgical books. Another beautiful, how my experience has evolved, you can see from this understanding of C2 neurinoma. You see, this is C2 neurinoma. And this article I published in 2008 with my experience of 60 cases. And this is the picture of C2 neurinoma. C2 ganglion is the largest spinal ganglion. Gastrin ganglion is the largest cranial ganglion. So we said in this article that this part of the tumor is intradural and subarachnoid in location. This is yellow. And these two parts are interdural in location. This was the article in 2008. Exactly 10 years later, I changed my concept and I said that this part of the tumor is also interdural. Interdural. You will not imagine, like for trigeminal neurinoma, if you know that trigeminal neurinoma is interdural, you don't have to expose the carotid artery. You don't have to expose the cavernous sinus. You don't have to expose the sixth nerve. Similarly, in this area, if you know that this is interdural, you don't have to expose the vertebral artery. You don't have to expose the spinal cord. You don't have to do anything other than just make an incision and attack the tumor and preserve the dura. And some of these cases can be done in very quick time if you understand this anatomy. And if you do not understand this concept, then you can go on exposing the vertebral artery and exposing all those things, and you can have quite a bit of difficulty in completing this operation. So this article of mine was published in 2018. You see how your experience changes, how your concept changes, and how your understanding changes with more and more and more surgeries you do. Now, acoustic neurinoma is my life, and no neurosurgeon on the planet can say that I don't like acoustic tumor. But no neurosurgeon on the planet can say that they really understand the acoustic tumors, because acoustic tumor is not just technique, it is a philosophy. In my understanding, acoustic tumor is the height of philosophy. In my experience of acoustic tumor, I have got 2 divorces, 1 suicide, and 1 attempted murder because of the facial nerve weakness. So facial nerve damage is an absolute devastation of the patient. You must remember. And total tumor removal. Many people talk of total tumor removal. In my view now, in my current understanding, total tumor removal in tumors more than 3 centimeters or 3.5 centimeters should not even be attempted, because your teasing of the facial nerve from the tumor capsule can, I'm not saying always will result in disaster, but that technical skill that you want to use and technical skill that you want to showcase, probably you want to make a video for your next lecture, can damage the facial nerve, and then that damage can be absolute, and that damage can be a killer. So don't take risks with the facial nerve in large tumor. Small tumor, of course, that dissection is much simpler. I nowadays don't even try to tease the facial nerve from the capsule in more than 3 centimeters. And I believe, and I firmly believe, that total tumor resection is not even possible, and total tumor resection should not be attempted in large tumor, and you have to save the face. Mohammed, your voice is coming. Okay, so in acoustic tumor in general and in all tumors, you should realize as a neurosurgeon your infinite potential to harm the person. When neurosurgeon can give life to the patient, neurosurgeon can give complete new life to the patient, but neurosurgeon can harm the patient. John, can you check? There is some noise coming, I think, from Muhammad. Okay, so you should realize your infinite potential to harm the person. That is what you have to remember in neurosurgery. You give life, but don't harm the person. And how you can do both these how can you achieve both these targets is on you, on your experience and in your life of neurosurgery. Colloid cyst is another subject of my great interest and in which I had written a beautiful article with my experience of 105 cases in 2002. Now, over the next 23, 24 years, my experience has become quite huge in this subject. And this article on colloid cyst is also one of the most highly cited article in the field of colloid cyst. And there are some beautiful things that we have mentioned in this article, and I wish that you read it. This is a standard subject. My approach is interhemispheric for all cases. My technique of cutting of corpus callosum has changed recently. My dissection has remained the same. Get to the colloid cyst, evacuate the cyst content, hold the capsule and dissect. You need two instruments, holding the capsule and pulling the capsule gently. And you can remove it in very quick time in a beautiful fashion. Intraventricular tumors is also one difficult chapter of neurosurgery. And if you see this numbers, 145 cases, which is, I believe, the largest number in the field of neurosurgery for large lateral intraventricular tumors. And all we have described a little bit of a different technique of removing, going interhemispheric and then removing the cingulum, part of the cingulum, and going lateral to the corpus callosum to remove this. So these are, majority of these lateral ventricular tumors are low grade. They are not, they become large in size. They are low grade malignant tumors. Most of these tumors are highly vascular tumors. So you remove them, you give them new life. But there is a potential to kill these patients. So their post-operative disasters are most common in these tumors. So you can be either here or there. You can give new life or you can have a disaster. So these tumors have to be learned, imagine this tumor is a benign tumor. It's a central neurocytoma. Intraventricular tumors are more often benign in nature. If you remove it completely, they are very vascular in nature. They are very huge in size. So if you are able to remove, you cure. But this curing, has to be learned, has to be understood, has to be performed, has to be achieved. And in this, you can have a very big disaster. If you don't do it properly, you can have hematomas, you can have hemiparesis, you can have an unconscious patient, then you need this and then you need that. So these are another. So this technique I have already talked about, nasopharyngeal angiopharyngioma. Another beautiful, I will say, one of the innovations of my lifetime. And in 1995, you can imagine 1995. See, I am proud of my work, but there are two things. One is being proud and one is having a pride. You can have pride, but you should not be proud. So I will say I have pride to operate, to introduce this technique. You can imagine, I don't want to be egoistic. I don't want to be artificial, but this is what I had described. And what a beautiful, just think about it, 30 years ago, coming from contralateral side and removing the other side tumor after cutting the FARCs. Nobody had described. Now many people are discussing about it. Some people don't refer to this publication. That makes me a little bit upset that such great innovation, if you don't recognize the publication, it is a little bit not so polite for me. Other thing we described is contralateral and ipsilateral bilateral interhemispheric approach for AVMs. For the first time, we described this in my publication in 1996, this publication, 1996. And that is quite an approach and quite an innovation at that time, 1996. Another beautiful approach that we described for the first time in the literature Middle fossa tumor. This dermoid is in the middle cranial fossa. To remove middle cranial fossa tumor from the posterior cranial fossa was described for the first time in the literature in this article in 2010. Nobody had talked about removal of middle fossa tumor from the posterior fossa. Now, of course, many people talk about removal of cavernomas in the thalamus from posterior fossa root, removal of amygdala and hippocampectomy by posterior fossa root. But this was the first time that such a tumor in the middle fossa was removed by lateral supracerebellar transtentorial route. So this was one beautiful article that we described. More recently, our work on white fiber dissection. Beautiful work, beautiful contributions from my department, and many of you have read these articles, and these articles are now very powerful articles in the field of white fibers. Here, if you see this anatomical analysis of supplementary motor area tumors and how these tumors can be removed en masse. So I will talk about this. And this is, this is corpus callosum. You see the beauty of, I never realized corpus callosum can have such huge, it forms the foundation of the whole brain. Did you know this? I didn't know this at all till we did these kind of dissections in my department, and this article was published. And I wish that you please read this article to identify the beauty of corpus callosum, beauty of its connections, and how you can design your surgery on the basis of these connections. I also described a very beautiful approach for amygdala hippocampectomy. Unfortunately, that was published as only a thesis, which is also a publication. In 1997, I described middle temporal gyrus approach for amygdala hippocampectomy. And this article was published on what are the fibers that can be involved when you do middle temporal gyrus approach, which fibers you need to save, which fibers you can save by this approach. Rather than coming trans-Sylvian, this approach, I believe, has got beautiful, this is an anatomical beauty that we described several years ago. And for the first, you can imagine this is a Pape circuit. This kind of Pape circuit taking out from the cadaver and placing it on the table was for the first time in the literature that we did this. And then, of course, various articles that were published, and you see this brainstem anatomy. Nobody, you see, of course, here I cannot undermine the contribution of Maximiliano Nunes, who did this along with other authors that you are seeing here. Beautiful work of anatomy and anatomical beauties. More recently, my concentration has been on gliomas. And I have no hesitation, it looks a little bit too egoistic statement to make. But I can tell you, you see, this is the title of this article, A Revolution. Low-grade gliomas were considered to be diffuse in nature. They were considered to be infiltrative in nature. But we said that low-grade gliomas and high-grade gliomas are confined to a named white fiber tract. They go along a tract and they displace the adjoining tracts. And on the basis, by virtue of its color, by virtue of its consistency, and by virtue of its vascularity, you can design a well-defined plane of dissection and you can remove these tumors en masse. Such an approach, limits the need for monitoring and all those things, and even awake craniotomy can be avoided in a reasonable number of patients, and you can do a radical resection. So this strategy, en masse tumor resection, on the basis of the concept that these tumors are confined, we published several years ago my experience of 74 cases. Now our experience is quite huge, and where we say that this, I have no hesitation to say that this approach is possible. The tumors extend along the white fibers, they displace along the white fibers, and there is a radiological, they respect the radiology. There is a method in the madness of this extension, and this method has to be understood. Imagine this tumor in the Broca's area. I don't have that kind of time to show you the whole video of this Broca's area dissection, but I have shown it on several occasions, and many of you must have seen this. Go around the tumor and you can remove this tumor en masse. Imagine this tumor in the premotor area, such a complex area, such a dangerous area, such a difficult area. But if you have this concept, you can come around the tumor and remove this en masse. And I have shown this video of this patient in several of my webinars. And many of these webinars you can get, there is John can give you the list, the link to my webinars, and you can go to all my, and this glamour dissection I have shown on several occasions. And this small little approach which we have described for deep-seated paraventricular tumors, this approach we have described, orbital cortical approach for lesion around the frontal horn. This approach has also some indications and some beauties. And more recently, we had worked on how this orbital approach, you can protect the uncinate fiber tract, you can protect the anterocommissure fiber tract, you can protect the IFOF and various other fibers to use this approach. Another fantastic thing that many of you have heard me on several occasions is my life with arteriovenous malformations. I must say that if you ask me today what makes you most excited in neurosurgery, what makes you, a little bit afraid of neurosurgery, what makes you a little bit jittery about neurosurgery is surgery for AV malformation, arteriovenous malformation. In several lectures of mine, I have mentioned that surgery of arteriovenous malformation is the last chapter of neurosurgery. Why last chapter? Or maybe, why last chapter is because surgery on these tumors, on these AVMs, you not only need your surgical technique, your surgical skills, your understanding of the pathology, but most important thing that you have to understand is to understand your own self, whether you can do it or not, whether it will be possible to start the operation and complete the operation. Because if you are not able to complete the operation, it has created a disaster. Many of these patients come with very marginal symptoms like only headache or only giddiness or only little bit of an ataxia. Of course, some small AVMs come with bleed and other things, but large AVM in general come with abnormal behavior, come with epileptic fits. So the symptoms are relatively marginal, and you don't even know that you will improve his behavior after surgery. You are not even sure you can cure the epileptic fits after surgery. So these are the things. And the surgery is difficult, surgery is dangerous, but surgery is cure. If you can cure, that is what you can do. And this is one large AVM. And in my journey of AVM, many of these AVMs, we have done huge AVMs. Like this AVM I did about 1 or 2 or 3 years ago was, you can imagine what a dangerous AVM it is, what a difficult AVM. But to even to realize that yes, it is possible. Yes, I can do it. Yes, and this patient, his only problem, he was running around patient, not that he was a sick person. Only thing is he did not get good marks in his school. He was not a good, intelligent student in the school. He was otherwise quite okay. So, but he used to have recently quite severe headaches, and that is why this AVM, if you realize that you can do it, then you can, and this we did it, and we did it beautifully. And this is the boy giving quite a foolish kind of smile, but he was like this before and like this after. I'm not sure he started getting good marks in his studies or school, but he is now cured of his problem. He's cured of his headache, and he's a new boy, and I'm sure he will become a handsome boy. So we published our series of 89 cases of large AVM. Large AVM with size more than 4 centimeter in lateral view, 4 centimeter in anteroposterior. So this is the largest published series on this subject, and this is a very big, beautiful, power of mine. This is pile AV fistula. These are not AVMs. These are having a different, and this series of mine, which was published some years ago, you see one large vessel and huge veins, but they are relatively simpler. You can embolize this vessel, but sometimes because of this large vessel, there is a potential for emboli to go and sucked away in the venous circulation. So open this thing, and there's no need to actually remove the whole thing like this. But during that time, this was probably my first case where I didn't know this subject properly. But clip the vessel, and that's the end of the story. This removal is not so difficult like AVM, but it is not necessary. Another, in my lifetime, reconstruction of skull base. There are several papers, several book chapters by me on how I do reconstruction of skull base. And you see there are several vascularized pedicle flaps, extended vascularized temporal muscle fascia flap, multi-layer flaps, vascularized osteomyoplastic flap, subgaleal fascia. This term was used in neurosurgery for the first time by us. Subgaleal fascia. This is a discrete layer, and you can have long facial flaps like this, and these were described by me in 1994, 95, 96, and more than 13 or 14 flaps I have described, and several chapters on this subject we have written. So this subgaleal facial layer that we described for the first time in neurosurgery is a strong and powerful facial layer that can be used for reconstruction. We also discussed the use of outer layer of dura for reconstruction. So this is a pituitary tumor. We use this mucosa. You see this sphenoid sinus mucosa, and used it for reconstruction as a pedicle flap and also as a free flap. You see, using vascularized pedicle mucosal flap. This is also this term. I was fascinated by this term vascularized, so I use this flap here. Another very important thing that we have studied and we have contributed to the literature without any doubt, some beautiful articles on brain abscess. And what is abscess? What you see this, some of these sentences words that you can see are absolute game changers. Fungi, what is fungal abscess, and brain abscess, how immunity helps and how brain abscess is formed and what should be done in brain abscess are some beautiful things that we have to know. Of course, the number of brain abscesses that we treat now has become dramatically reduced from what we used to do when I started neurosurgery. Now, I will say I hardly see any brain abscess, but brain abscess, understanding brain abscess is a very important part of our learning of neurosurgery, and these papers can give you some solid information. We have also described some shunts from the fourth ventricle and third ventricle to the craniocervical subarachnoid space for CSF fistula, employing lumbar theca for meningomyelocele. If sometimes meningomyelocele you do and you get a CSFD, it will be a big disaster. For arachnoid cyst, we have described this Teflon strips as a shunt, some beautiful original techniques. So if you realize what I have been showing is, I have more than nearing 300 techniques I have shown you in this presentation, and you can read the articles which I have presented. And this is another technique which forehead advancement. See, this is the preoperative and this is the posterior. You can see the forehead has been expanded, and I had used this kind of technique. One screw in the root of the zygomatic bone and one in the base of the zygomatic bone, and this advancement. You see this advancement, and this patient had come. This is another patient. You see the forehead, of course, the hair are, but you see this technique of forehead advancement we had described several years ago, 25 years ago. You can see this. Then another strong, powerful presentations by me, which I think very few neurosurgeons are really interested in those kind of philosophical presentation. Imagine the presentation title, Neuraxial Healing. Can you imagine this title? Can you imagine the title, Equalization of Neuraxis, the wondrous neuraqua of CSF? Can you imagine the title of Eyeing the Skull Base? Can you imagine the title of Muscle and Eternal Eco-Friendly Mobile Automobile? Can you just imagine a title named Integrity, Immunity, Reactivity, Restorativity of Brain Abscess? Can you just imagine the title Anti-Cytosis, Radiopalliation, Chemopalliation, and Neuroaxial Neoplasm? So these are some of my most beautiful hemangiopericitomas of meningioma, a malignant challenge, foramen fallacy, beautiful articles and academics and Indian neurosurgery. I wish that you read some of these articles and many more, which I have not shown here. Those are, in my view, some like equalization of neuraxis, the beauty of fluids in your body. Another paper I had written, fluidity of body. Imagine when you are standing on fluids. Your brain is floating on CSF. A pregnant lady's fetus is floating in amniotic fluid. You are standing, you are weightless. You can move because of fluids. There is disc which is fluid. There is in between the bones, in the joints, there is fluid. Under the eyelid, there is fluid. So all movements in body are on fluids. And you are weightless because of your fluids. Your movements are on fluid. If there is loss of fluid between the knee joint, you will have pain. If you drain CSF and drain CSF from the lumbar puncture, there will be headache, and you will be forced to lie down because you will have headache, and your brain will be touching on the floor. So these are some beautiful things that I wish that you read, and I wish that you enjoy, and I wish that you use them in your neurosurgery. So this is tenting stitch, this was probably my first technical paper in 1992. And of course, many of you know my paper on C1, C2 fixation, which I described in 1988 as a 27-year-old boy. And that technique of C1, C2 fixation, I will discuss in my next chapter, next book, which I am going to present on Tuesday or Wednesday. John will give us the date very soon. This stitch, you see this stitch? Before closure, you can stitch these two layers, and that keeps the scalp closely approximated to the skull or to the pericranium. I call them tenting stitches. So these are some of my students and some of my anatomy dissections. If I think I have achieved anything, it is because of constant work, long-term work in anatomical laboratory. And so this is one beautiful sentence that a good teacher explains, a great teacher inspires. So my dear friends, this is me, and this is me in my various formats and presentation. And I wish that you like me, I wish that you love me, and I wish that the young people who are listening to me get inspired by some of these things. And this is passing on the baton to my next generation. This little girl that you are seeing is my daughter. She's becoming a neurosurgeon. And those who have been, I have got fellows from more than 52 countries. I have got fellows from more than 600 fellows have gone through me in various parts of my neurosurgical life. And I have the burden of handling large tumors, big problems. And I must let you know that I have enjoyed my life in neurosurgery. So just a small little bit hyper statement that I have to give, that I have come here not to answer all the question, but to question all the answers. So thank you very much, my dear friends, and I hope you have enjoyed this little presentation. Thank you, John, for organizing this for me, and thank you, John. And I wish that you keep this in the list of the other lectures. And I wish that can you pass on the list of my lectures so that those who want to that link that you had sent, people can open that link and get into that link.
Moderator, take over.
You-
Go ahead, George.
Your voice is not clear, John. Your voice is not clear. Harsha, Harsha? Yes. Was my voice?
Atul, can I comment?
Yes, Harsha, yes.
It's a beautiful journey you've shown us how you've grown. Although we both have grown together, but you've outgrown everybody. So I may envy you in that way, but yes, your hard work and unbelievable journey you have got, and you not only the various papers, but the techniques which you have described is something amazing. Majority of papers I have seen it and read it, and I've seen you operating so many times. And I 100% agree with you. One thing, never say I have cured the patient. Meningioma is meningioma, acoustic is acoustic. Everybody shows different technique, but the kind of a speed which you have, amazing. And every time I feel how he manages to do this thing in such a short period of time. And there is a great to learn from you. You are definitely a dynasty in the neurosurgery. What you have given to most of the people in the world is really cherishable and unbelievable. And yes, we have to believe now since we are seeing you doing it. And despite of you are out of government hospital, still you are doing in private practice so much of work, which is not done by many neurosurgeons here. So it is something beyond imagination for many people. It is nice to give a talk. I have done somebody's case and removed it, and then when you do yourself and you realize that you are in trouble, and when they come with the recurrence and what happens, so you are saying something good and very truthful things about the neurosurgery and whatever the truth is there. And I'm sure the all the attendees and everybody will be enthralled by your journey. Superb work, and I'm sure you will keep it up. It's not going to end. Maybe it may be a new beginning in your life.
Thank you very much, my dear Harsha, for all these nice words. When they,
Yes,
when they,
yes.
when they come from a colleague, when they come from a friend, when they come from a person who is a senior neurosurgeon, and when it comes from a person who has traveled with you, it gives you some special pleasure and special, believe me, Harsha, you have given me a lot of pleasure in my life, and I thank you for your journey together with me.
You deserve everything what I've said. It is not that we are just trying to flatter you. It is that something really truthful. You are a very tall stature in the neurosurgery, cannot be denied by anybody in the world. Not only me, anybody in the world. Something which is very, well, anybody has to learn from you rather than, give you a lecture.
Okay. Thank you. Thank
You are
you.
an
Thank
institution yourself. You are a teaching institution yourself. We at this age also we learn everything. When I hear, I say, oh, I don't know all these things which he is telling. And philosophy of neurosurgery mixing with everything. So many times you have given a philosophy of animals and human. Something very thoughtful you You got a mind to think over that. Super, super. Keep it up.
Thank
Keep
you.
us enlightening, not only me and everybody.
Thank you. Thank you.
Thank you.
Harsha.
Thank you. Yeah.
Professor Goel, phenomenal journey, and we
Thank you.
still look
Thank you.
forward to learn from your work and your talks. I had the privilege to meet you when I was almost a junior resident in neurosurgery back in 2003 and 4 when you visited Pakistan. So it was wonderful to meet you in person and got that feel of person to person meeting and hearing your out of box philosophies and concepts which are amazing because you to me you had a very strong personality. You still have a lot of criticism when you do when you outshine your colleagues. You publish, you work. I remember one of colleague who was asking you, how come you do all that work in a short years of life? And now I'm sure Professor Parekh has mentioned that how speedy your surgical work is. So I would like to have your comments on certain things which are going on in neurosurgical practice now. One of the thing is neurosurgeon and neurosurgery is losing the driving seat in many places, like spine, like neurovascular, like many other things. So it is painful when neurosurgeons are out of the discussion and a patient goes to a radiologist and with a neuro-oncological issue or neurovascular issue, big AVM or tumor, and that radiologist or even a neurosurgeon refers him directly for radiation. And whatever happens afterwards in form of complications, we are supposed to treat those complications as neurosurgeons. And if everything goes well, nobody keeps us in a loop. That's something we are losing. And in a specialty, especially in lower middle income countries, our fraternity is not supportive for us doing as a neurosurgeons doing mastery in these fields because they are more comfortable working with the non-neurosurgeons. Your comments and how you see this all.
See, Dr. Atta, the problem is not the problem. The beauty is the science will go on evolving. The science will go on improving. Most important is patient safety is the critical issue. Imagine if you are a patient and if I say you will lose your facial nerve after surgery, and imagine if somebody says I can cure it with gamma knife or something like that, you will certainly as a patient prefer gamma knife because when you are operating as a human being. And there are big chances. Of course, there are indications of acoustic tumor is a completely, in my view, a surgical issue. But suppose we become over enthusiastic and we try to dissect here and dissect there. We try to remove pituitary meningioma. We know that you can, damage and you can devastate the person. Similarly, for AVM surgery, how many people in the world can do AVM surgery? You know how many people can do. You know how many people can do giant aneurysms. You know yourself how many people can do. And how many people can surgically deal with giant aneurysm. You know how many people. When I was a youngish boy, the most important surgery for me was cavernous sinus, aneurysms in the cavernous sinus. So I used to dissect and do and all those things. And I know how many times I have blasted the carotid, how many times I have, and now you see how people can do with flow diverters beautifully. So science has to progress. Only thing is, and we have to, as neurosurgeon, go along with that progress. And we have to make ourselves, we have to treat, we have to make ourselves relevant, we have to make ourselves safe, we have to, get along with the advancing techniques. Like we have to also start learning endovascular techniques. We have to also go along with that, breeze. So basically, all those things are evolving, and we should not take them as negative. We should not take them as competitor. Really, I'm telling you, we should not take endovascular thing as competitors. We have to be particularly careful when we use gamma knife, and also we have to be very much sure that we are not using any of these things for commercial reasons. Now, if you see for smallish tumor, if the residue, you give gamma knife and patient has to spend so much, and these are commercial gimmicks also. So we have to, as individual neurosurgeon, we have to see to it that we are not doing something and getting influenced by something because there is a commercial need involved. So we should not overuse any technique. And there are several indications where surgery is the best. Like for AVM, I am still saying for a lot of AVM, surgery is the best option. But doing surgery is quite a dangerous and can create. So we have to learn ourselves. We have to make ourselves more and more skilled. We have to learn more and more techniques. We have to learn to be safe. If I can say that I can remove acoustic without giving any facial weakness, small acoustic I will do without giving facial weakness, of course the patient will come. But you have to give that confidence to that patient. You say to the patient, yes, I will remove your AVM without any problem. You have to be, first is you have to be yourself confident, and second thing is you have to instill that confidence in the patient, and you have to do confidently. Imagine if small AVM is, you're not yourself confident, you cannot play with the patient. You give gamma knife in that situation. You give some embolization here and there. So we have to, I will say that we should not be negative with the advances. We should be positive, and we should take them in our stride. We should take them in the, where we can improve and help the patient. Of course, we should not be diverted by any kind of personal or commercial or technical interest that comes in picture in some occasion. And we have to be sure. You should read one of my philosophical lectures, one of my philosophical articles on radiation. I have mentioned, we should call it radio palliation. Surgery is the final thing. Surgery is that you remove it and show. Radiation is you probably might help. Chemotherapy is you probably might help. So this is surgery. Surgery is as long as you can use your knife, as long as you can use your knife with reasonable safety. That is one article that you also should read about my cavernous sinus meningioma. I showed small letter to editor where I have written this beautifully. Go to the tumor, remove it radically. Radical is the word, but safely is another word. And if you have to leave some tumor behind, folded hands, you pray to God that it should not recur. And if it recurs, go again if you think you can be safe. If radiation comes when you think you are not safe. So there are many things in all these advances, and we should take them in right and best perspective for the patient. Atta, this is my answer to your question.
Thank you so much. Another thing, in the public sector, when you were doing complex cases in 90s and late 80s, so were neuroanesthetists, were neuro ICU people welcoming those complex long procedures?
No, you have to instill confidence in them. If you are yourself not confident, if you are yourself jittery, if you think that, huge blood loss and all those things are possible, means I created disasters, I created flutters in anesthesia department, I created all those kind of things, but eventually they liked me, and they loved me, and they were with me, and we, regulated. I used to do, 8, 10, 12 cases a day, and big cases in one live surgery conference which I did. There were 250 people watching. I did 9 cases in one day and 8 cases in the next day, 17 cases in 2 days. I did one conference live from India and it was relayed in London. I did 5 cases in 4 hours. So that, I improved. I became faster. I became surer. I became safer with improving with times. And you have to have a big team with you. I'm not just a single man. You have to have a beautiful, partners with you, assistants with you, nurses. So important is the nurse. It is not just the anesthetist, the nurse. If you have bleeding, the nurse will start jumping. And if you have bleeding, too much bleeding, the anesthesia team will start jumping. And they might consider you a hero, but when they see the blood loss, they may see that you are, you yourself fall down in their eyes. So it is very important subject. Neurosurgery is my life. Neurosurgery, I have loved neurosurgery. I have lived neurosurgery. I have grown in neurosurgery, and it is a subject which is absolute. And that is what is, my dear Atta, that is what I have to tell you.
Thank you so much.
John, your voice is completely not audible.
I'm sorry. Go ahead.
Thank you so much, Dr. Goel. You're indeed a great teacher because you have inspired us all. As a medical student, I was never so much motivated to pursue this field and do something meaningful. So I had a couple of questions. The first one being that
Before you ask me, there is Yang Dong sitting here. Let me ask Yang Dong if he wants to ask something. There is very senior, some doctors are sitting. I will let you answer your questions a little while later. Mohammed, you are there?
sure.
So I
Yes,
think,
yes, I'm here.
okay, Mohammed, your questions, my dear Mohammed.
Yeah, hello, I just want to say thank you very much. That's the first thing for your life of neurosurgery that you are giving to all of us. Your journey that you just showed, it's inspiring to the young and the senior surgeons, actually. Your contribution to the field by this number of publications and this huge number of patients and surgeries that you have done, that I'm sure that you give your life and your family's life, and you were your whole day thinking, working about everything. You're also inventing your way of inventing new concepts, new techniques every day, even now, even earlier, for this 20 or 30 years. I just want to say thank you very much. I will ask one good question, because you have the biggest experience about it. Your way of doing sitting position, and a lot of senior surgeons that they're really afraid of. I think you lived your life with doing just sitting position. So you can just give us a small talk about it. Thank you very much.
You answer this question. You meditate in which position?
Sitting position, doing posterior fossa sitting position.
Sitting position, many senior neurosurgeons of the world, like Yasser Gil, like Sami, like Malice, like Cushing, like various senior most neurosurgeons of the world, loved sitting position. But I can also tell you, sitting position has to be learned not only by the surgeon, by the anesthetist also, sitting position. But it is a beautiful position. I am not saying I have never had any problem with sitting position. I have had problems with sitting position. But it makes your life so beautiful and simple and strong that you should learn and you should do, and in right indication, not in wrong indication. Because if you do in wrong indication, you can probably be not so, you can harm the person. So that is the answer. And thank you, my dear Mohammed. You have been my favorite person, you know it. And I want you to develop, I want you to progress. You are a young boy, and I want you to become a you are a handsome person, but more handsome surgeon in the future. Okay, Mohammed.
Thank you, sir. Thank you very much.
No, John, your voice is not at all there. I don't know, some huge problem with your mic.
Say something about that, Arthur?
We can't hear John.
What I can see is the next spine session on Wednesday. So I will present my book, spine book, on this Wednesday. John, I could see that. I didn't hear you, but now this young boy was saying something. Can I just ask him what he was saying? Harshal? Harshal? No. What was this name? Dr.
Rishikesh, sir.
Yes,
Thank you
Rishikesh.
so much.
Yes,
Thank you so
Rishikesh.
much.
Ask your
Yes,
questions.
sir. Yes,
Short
sir.
and sweet.
Sure, sir. So, sir, throughout your talk, you told about innovations and newer techniques. So, as someone who likes innovation and wants to pursue neurosurgery as well, what advice would you like to give?
So, neurosurgery is a beautiful subject. Neurosurgery is a fantastic subject. You have to learn, you have to come into neurosurgery because neurosurgery is not a profession. You come into neurosurgery to, if you believe in yourself, if you think you can do it. You don't come to neurosurgery because you want to earn money and you want to be a rich man or you want to buy a new car or you have a good house. It is no neurosurgeon thinks of these things. What neurosurgeon thinks is about his patient, how his patient has done, how his patient is doing post-operatively, how much problems you had and how you handle those problems. These are the things that give happiness to you. And at least means you, if you are willing to get that kind of happiness, you enter into the field of neurosurgery because here you give new life. Here you give new vision. Here you give new kind of breathing. Here you give new kind of limbs. You give new. That is, if you have that will, if you think you have that skill, if you think you can dedicate your life for these kind of things, you enter into this subject. If you think you want to be a rich man, if you want to have a beautiful car, then there are several other ways to earn money. Like you can have a shop rather than coming into neurosurgery. You can have some kind of share market dealings to make money. But if you want to have, if you want to share your life with your patients, then come here. You understood, my dear?
Yes, sir.
Okay.
Thank you,
Thank you so
Professor.
much.
Thank you,
Thank you.
Professor Atul. It's like an unending desire to learn from you. We can go on for another hours, but the time is already to say goodbye for now. And
Look,
we are looking forward for Wednesday's spine book lecture.
okay.
And see you all. Thank you so much for being here.
A
Thank
magic.
you.
Thank you.
Thank
Thank you,
you, John.
Atul. Thank
Thank
you.
you, John. Thank you, John, for doing
Bye-bye.
this. And thank you, John, to take my message right in the interior of the corners of the world. This forum that you have selected, this web-based, Zoom-based, I go to any country, I go to any small little country, people know me. I say, how you know me? They said they have heard me on webinars and Zoom. And John, what platform you have created for the world. Congratulations to you. And I wish you have more strength on your shoulders and your shoulders become stronger and more powerful. Thank you, John, and
Okay.
bye-bye.
Bye. Bye. Okay, we're stopping here.